today we're honored to have again Dr. Robert Shiroff, CompuMed's medical director, to present some information on how serial echoes may help save more lives and increase the number of viable hearts for transplant. I think most of you on this already know Dr. Shiroff, may have talked to him at 2 o'clock in the morning when you're managing a donor case. And what you might not know is that according to CompuMed's estimates, Dr. Shiroff has read the most donor echoes ever than any other doctor, including all of our other reading doctors at CompuMed. And, you know, he's used this experience and all his other vast experience on a daily basis to help us improve our echo reading processes and our heart cath protocols that some of you are familiar with and saw that webinar also. And so today he's going to provide some information on serial echoes. And just a quick note, during the session, please go ahead and submit questions. And at the end, time permitting, Dr. Shiroff will address these. And without that, Dr. Shiroff, please go ahead and tell us more about serial echoes.
Thanks, Laura. And thanks for everyone for participating today and coming and listening to my spiel. Basically, the question is, why do we do serial echoes? And the reason is that there's an expectation that left ventricular systolic function will improve with time in a brain-dead individual or even a DCD patient. The other side of the coin is why not to do serial echoes. It sounds simplistic, but if the initial echocardiogram shows the heart is transplantable, then there's no reason to repeat an echo. The other reasons not to do them, and this one is a hard one for a lot of folks, is that the resistance to hospitals to perform timely serial echoes. This gets down to the basic issue of technician time for a dead patient and the hospital's resistance to provide the care in a timely fashion, because we need echoes at 6 or 12 or 24-hour repeats, possibly a couple times, and they wonder why we're bothering to do this. The third one is cost considerations, and besides the cost of our services and the cost of doing an echo, the ICU utilization is a big one for hospitals in the system. Obviously, you're tying up an ICU bed, and if you have not ever had heart recovery or organ recovery for the patient, you continue to utilize that bed while you're waiting. The other is the cost of the study and delaying other organ transplants and potentially losing them and affecting the organ transplants as time goes on. We know that hemodynamics can deteriorate and kidneys can be injured and may be lost for transplant. The next one is legal considerations. It sounds ridiculous, but there are situations where homicide is questioned or there's questionable cause of death, and the coroners or the district attorneys or other legal entities get involved in the cases, and they don't want to wait for 24 or 40 more hours. And the last one is social issues, and this involves the family that has had a blow, obviously, to them emotionally, that their loved one is legally dead, but sitting there with a ventilator going. And the question is how long we have to wait till we can take care of dealing with our own grief. So this becomes an issue, and a significant one for families. Let's first talk about the heart function. When we're talking about ejection fraction, when I did a dress rehearsal this couple of days ago, someone said, well, how do you define ejection fraction? And I realized I hadn't defined it, so I put the slide in. And basically, it's the performance of the heart. When the heart contracts, a certain amount of blood is left in the heart. What is ejected with each beat is called the ejection fraction. It's put as a percentage. It's very simply the end diastolic volume. You take the end systolic volume and you subtract it from the end diastolic volume, you put it over the end diastolic volume, and you multiply by 100. Well, how do you measure that? In echocardiography, which is the most common way it's measured because it's so easy to do, there are at least 3 different techniques for measuring it. One is called Tychotes, one is called Simpson. Tychotes is basically an ice pick view and a 2-dimensional echo, and you're measuring the walls moving toward or away from each other. And you get the measurements, and you then make certain assumptions physically about a cylinder of revolution, which is more complicated than you need to know about. But from that information, you calculate an ejection fraction. The next way is with Simpson, which is a volumetric measurement, where they actually try and measure the volume of the ventricle by drawing end diastolic picture in various views of the 4-chamber and 2-chamber and short axis. And even and left parasternal view as well. And in that circumstance, another equation is used to determine what the ejection fraction is. The third one is in 3D echoes, which does it by computer, and more mumbo jumbo than I care to go into right now. In addition to that, there's other ways to measure ejection fraction. It can be measured with heart catheterization. When you do a ventriculogram, or this dye is put in the left ventricle, and you watch in the RAO projection, particularly, the operator will draw a picture of the ventricle at end diastole and end systole, and the computer will then do a computer analysis and come up with an ejection fraction based again on a bunch of equations. There's also 3 more methods for measuring ejection fraction. You can do it through MRI, you can do it through CT, and you can do it through nuclear. You ask why all these measurements available, and there's so many different ones. Well, my experience in medicine has been when there's a lot of different ways of doing something, it tells you none of them is perfect. And that's the case. That's why when you read an echocardiogram, and when I read an echocardiogram, it has a box that says visual ejection fraction. That's an estimate of the experienced cardiologist view of the heart and what the ejection fraction is. Most of the time, we agree pretty much, but when you have segmental dysfunction or when you have other issues of the heart, you can disagree significantly with a measured ejection fraction. So I'll stop there about ejection fraction because that's more than I ever wanted to talk about it. Well, why the expectation for improvement of ejection fraction in a brain dead individual? And that depends on the etiology of the ejection fraction, of the decreased ejection fraction. And probably the biggest, most important part of this whole thing is downtime. If someone is injured in a trauma, injured with a cardiac arrest secondary to an overdose, a cardiac arrest secondary to hanging, to other suicide attempts, or a CNS bleed, it matters with what the etiology is, and as well as if you have a cardiomyopathy of Takasabu, which we'll talk about in a minute. Well, let's talk about CNS bleeds for a minute. First is the blood pressure instability. And those of you who have cared for patients with subarachnoid hemorrhages and bleeding from an aneurysm acutely kills people because they herniate. They get marked hypertension with that. Blood pressure is in the 250s over 130, 140s. And if they're going to survive, which our patients have not obviously, but if they're going to survive, blood pressure has to be lowered very quickly. LV dysfunction occurs secondary to blood pressure rises and also secondary to some myocardial injury that can occur with subendocardial ischemia. And there are neurohumoral effects associated with intracranial bleeds that are complicated and not well understood, but can cause LV dysfunction, which can be transient. And we've seen lots of recovery with CNS bleeds. And this is one of the areas which we like to highlight and think seriously about doing serial echoes on. Cardiac arrest is, as I mentioned earlier, the most important thing is downtime. And I discovered in trying to come up with slides and pictures to show you of echocardiograms and taken serially by our people here at CompuMed and read serially by CompuMed cardiologists, is that we have not the kind of data we should have. We don't have a database, and we need to form that. I think it's going to be up to the OPOs to think seriously about getting a standardized form where we can document what the cause of the patient's brain death is, or DCD death is when it occurs, how long they were down if they had downtime, what the cause of the downtime was, if you have that irrelevant, and other issues which will then allow us to come up with some better handle on how to better handle this. Secondary to trauma cardiac arrest is secondary to hypotension, hypovolemia, and shock, which can cause brain injury with decreased perfusion of the head and swelling and herniation. Secondary to drug effect with drug overdoses. And we'll go through some of the various drugs and the problems inherent in those particular entities. Suicide attempts so many times is respiratory depression with opioids, with hangings. You have trauma to the trachea and you have respiratory arrest as well. And that's the primary cause of death. Cardiac depression occurs with respiratory depression and hypoxemia. And Takasabu's cardiomyopathy, so-called sad heart syndrome, is a segmental dysfunction, which occurs in depressed patients, which goes back to suicide attempts. And in that circumstance, we would see an abnormal ventricular function. And in the outpatient setting or inpatient setting, in patients who have survived or gotten to the hospital without having a brain death or an arrest with Takasabu's, they will many times get better with conservative care. And the question is, can we make them better in brain death individuals? And that's yet to be determined. There are some people that are doing some studies looking at that now, from my understanding, and some trials being some throw at the wall and see what happens with the kind of events. Let's talk about the drugs for a minute, if we may. Opioid effects on the heart are many, direct and indirect. The direct effect is infective endocarditis occurs with with intravenous drug use of any kind. So I just throw that in the opioid category, but it can be thrown into the methamphetamine category as well. But usually we see that on an echocardiogram. I'll tell you that we recently had a case that I read, that I reviewed and 3 other cardiologists reviewed, where I did not see the endocarditis. And the surgeon, after heart recovery, appropriately looked at the heart, and looking through the atrial appendage, they saw the left atrial where it was cut off from the donor, and looking into the heart and looking at the mitral valve, saw a small vegetation. We went back and looked at the echoes and couldn't see it, and we could not see the small hole that was reported as well. The interesting thing was this last echo was done more than 48 hours after the one that we had read as not having endocarditis. Did it occur during that time frame? I don't know, probably not. We probably just missed it because this test is not sensitive enough to pick up small lesions. That's one of the reasons you have to keep checking these hearts even after they are recovered. The other thing that happened, direct effect of opioids, is prolonged QT interval. QT interval leads directly to, with a prolonged QT interval, you have directly to dysrhythmias like torsade de pointe, which is like an in-between ventricular tachycardia and ventricular fibrillation, can lead to death. Decreased cardiac output can occur with the direct effect of the drugs, and bradycardia can occur. And we're talking about OxyContin, heroin, fentanyl. Bradycardia occurs as well. The indirect effects are respiratory depression, which is what we deal with most of the time when patients don't survive, and cerebral depression. So opioids are bad drugs to have in the system. And the question is, as they wash out of the system, if the patient is brain dead, what is the expectation that the negative effects on the cardiac status will be improved with time? And it depends on the downtime to a large degree, as well as the amount of drug involved. Methamphetamines are bad actors all across the board. Their use is rising globally, resulting in significant morbidity and mortality driven by a poorly understood increase in multiple forms of cardiovascular disease. That's a mouthful, but it's true. It may provide cardiovascular disease through catecholamine toxicity. That is increase in adrenaline and noradrenaline, and we'll see that with cocaine as well. And less effects through the direct effect on the cardiac system and the vascular tissue. The use of methamphetamine is associated with pulmonary hypertension, particularly in patients who have a specific genetic abnormality or genetic finding with polymorphism in the metanephrine catabolizing enzyme carboxyesterase, number 1. Obviously, we don't know that one, and that's a genetic test, and we have to do a right heart cath or look at the tricuspid regurgitation or tricuspid flow across the valve to estimate pulmonary artery pressures in the setting of methamphetamine. Next issue is symptoms of myocardial infarction with methamphetamine. It result from either acute cardiac vasospasm or enhanced atherosclerotic plaque formation. So chronic methamphetamine abusers get more heart disease, more coronary artery disease, as well as get vasospasm. This is an issue that leads a lot of times the transplant centers, after in the decision to request heart recovery, to proceed on and ask for heart catheterization. And the coronary arteries are particularly interesting to those centers, along with the PA pressures. The last thing is remodeling of cardiac tissue, where the heart left ventricle dilates to a cardiomyopathy and may enhance susceptibility to cardiac rhythms. We don't usually have a problem with this if we get an adequate echo, because a dilated cardiomyopathy is one that usually is not reversible. It takes a while to develop a cardiomyopathy that's with dilatation, and therefore we don't usually expect it to resolve in the time frame required to recover the heart. The last bad actor I'm going to talk about is cocaine. And it's a bad actor. You can see a nice little diagram here. All roads lead to death. Sympathetic output and catecholamine toxicity leads to increased heart rate, increased blood pressure, increased contractility, or improved ejection fraction. And that setting leads to ischemia of the myocardium because the heart rate is so excessive and the blood pressure is so high and the contractility is so high. The so-called double product, blood pressure times heart rate, determines to a large degree oxygen requirements. As O2 requirements increase, you get relative ischemia of the heart, which can lead with the setting of vasoconstriction and coronary spasm to ischemia and infarction. And we obviously are already dealing with the death of the patient, possibly through this mechanism or possibly through a local anesthetic effect where they get rhythm disturbances with, again, QT prolongation, QRS widening with the ventricular rhythm disturbances associated with that, which leads to LV dysfunction and to death via various mechanisms that have already been defined here. So cocaine's a bad actor. This is why so many centers now are asking for heart catheterizations to be performed on donors, on the hearts, and why we're reading more of those for you folks. Someone just slipped a question on the board there. Let me get out of my screen. This is now we're going to start looking at echocardiograms. And we have 3 cases. And I wish I had better histories for you, because I don't. I think this one was a gunshot to the head, but I'm not 100% positive, and I won't stand by it. This is an echocardiogram. Here we see the left ventricle. This is left ventricular contraction. This is the septum up here moving, and it should be moving in toward the arrow I'm showing you. And the posterior wall should be moving in toward the middle. And if you had an ice pick view, you would stop it and you to diagram it, measure the systole and diastole, end systole and end diastole, and you do the equation that's used for tie codes. This is the left atrium here. Again, it's anatomy, so you remember from last time or the time before, where you have the mitral valve. Blood flows in from the left atrium to the left ventricle, then pumped out through the left ventricle, through the aortic valve, to the aorta and to the body. This is a depressed ejection fraction. It was estimated at 20 to 25%. We cheated over here to show you what these are. And that's based on a report performed by one of the other readers for CompuMed. This is another view. It's the fourth chamber to show you this heart is not contracting well. Here again, it should be moving this toward the center of of the chamber. And you can see this moves a little bit, but not very well. And one of the things that's nice to have always on an echocardiogram or an angiogram is having an EKG, so you can see systole and diastole. But I think you can clearly see when the heart is coming in and when it's relaxing. This is the mitral valve here, left atrium. This is the right atrium, tricuspid valve, and the right ventricle. You don't see the outer wall, the anterior wall of the right ventricle. This is called it's almost a good 4-chamber. And you'll notice these echoes that they're not all perfect. That's the nature of the beast with echocardiography, particularly in patients who are ill, in the ICU, ventilated, and all the rest of the things that we were dealing with. They've had trauma, they have chest tubes, they have subcutaneous emphysema. They have all kinds of issues that make transthoracic echo difficult and challenging. This is a report from the first study that was done by Dr. Simpson. He called it 20 to 25%, which we showed you up here. The next series was done several hours later. You can see it's a little better. The septum's moving in a little more, and this was called 40 to 45%. We'll show you the 4th chamber of this one as well. Again, I think you can see it's a more vigorous contraction. And this one was called 40 to 45% by Dr. Simpson again. And we try and have the same reader read them all if we can, if time and circumstance allows. This goes for continuity. But if not, we're all very, very close to reading, and the experience level is really good. This is the 3rd echo on the same patient. This one's 50 to 55%. See how much more vigorous the septum is. And one of the things we learned from this, getting this together this time, is we don't have the technology available to us yet to be able to show you side-by-sides of the serial echoes of the same view. Many times the views aren't identical, but they're as close as we can get. But I think you can ballpark that and see how much better that is than the first echo that you saw. This is the 4-chamber, close to a 4-chamber view. And again, 50 to 55 is probably reasonable for this one. On this one, there were 3 echoes done. There was a 4th one done in the middle we didn't get to read. But you can see the time frame here at hour 0 when the first echo was done. We got 25 to 30%, 25%. Recorded as 20, measured as 26. I'm sorry about that. I'm technology challenged sometimes. 42% for the second echo and 55% for the third echo. And this was over 77 hours. And I read the third one. Next series begins with a little better echo, slower heart rate, and we have the EKG on this one. Same kind of view, the same parasternal long. This is as close to a 4-chamber as I could get on this one. And this was called 45 to 50%. It was read by Dr. Simpson again. See, this is improved here. This is more 55 to 60. It's contracting much more vigorously. This is clearly a normally contracting heart. Not exactly the same views, but close. This we only have 2 for our series, but you can see the difference in ejection fraction went from 42 to 59% over 28 hours. So this one improved dramatically over a shorter period of time than the first one. Third study, this one we called 40 to 45%. Same views, a little faster heart rate. When we read them, sometimes I slow the heart rate down to get a better look at the wall motion. But the technician can stop it when they want to. We have to stop it when we can, when we're reading these things. This one was read by myself. I called it 40 to 45. Second echo, a little more vigorous. A lot of artifact here. It looks like the ventilator is set at a high frequency ventilation, or at least faster rate of ventilatory rate, and you're seeing the lung tissue come in the way of the transducer. But I think you can appreciate that it's an improved ejection fraction. I called it 50 to 55%, or I think that was me. It's the 4-chamber again, still tachycardic, but you can see how much more aggressive that heart is in beating compared to the first one. That's the second case, second report. And the third one, the same patient. A little better again. Again, difficulty with the ventilator. If we get 1 or 2 beats we can look at, we can make a judgment, and the technician stops it when it's best for them to do their measurements. And we said 55 to 60 on this one. Again, here's 3 time intervals up to 51 hours on this one. So there's a long interval between the 21-hour one and 51-hour one, but it did not that much improvement. We drew the line, the yellow line, at 50% ejection fraction. Some people call that normal. Some centers require 55% for a transplant. A lot of centers will look at the heart at 50%, with the hope of the expectation that they can make it some better. We'll stop here for questions, and there were some questions submitted earlier at your request. The questions were put to us, and I'm going to try and answer them. First one is, how long should you give a heart to recover? It's a great question. I didn't do that. That wasn't me. How long should you give a heart to recover? Well, the ideal world, you'd go to max. You'd do it forever, until you got a heart you could transplant, if it was possible. Obviously, that's not practical. And I think the limitations are related to those why not do serial echo type of things. It's other organs at risk. It's the cost in all the ways I listed before of waiting to do a recovery of the heart if it's doable. I think we need more information as to know what the optimal time is, and there are given circumstances that may be different for different circumstances. That's my guess. Frankly, it's going to be the case. So it's a great question. I don't think we have the answers. I think if you have a heart with the downtime was reasonable. By that, I mean 30 minutes or less, and you have a stable rhythm, and you have you got an early echo that showed 30 or 40% ejection fraction, and you have the wherewithal to get a second echo at 12 hours or 24 hours, I would strongly suggest that. But whether it's going to recover at that time, it may give you a trend that it's showing signs of recovery, which will then encourage us to urge your supervisors to wait another 12 hours and repeat it again. Because as we always mention, a heart saved is a life saved. What can I do as a donor coordinator to help the heart recover, if anything? Well, I think you have why does it do that to me? I think that the answer to that is that you try and keep the donor as hemodynamically stable as possible. Optimize fluids, decrease the catecholamines if you can by reducing pressors if possible. Make things as good as possible for this person as if they were alive from a hemodynamic point of view. So you want good filling pressures, you want adequate volume load, you want adequate maintenance of blood pressure and respiratory needs, you want them well oxygenated, and then you say a prayer. That's basically where you're at. What pressures are best for heart while trying to recover? Well, certainly whatever pressure will cause or adequate. I am sorry, this keeps skipping ahead on me, and I don't mean to be doing that.
It's okay.
What pressures are best for the heart while trying to recover? I think that clearly pressures that allow organ perfusion. If you're making good urine, you're perfusing the kidneys, that pressure is adequate. If someone is known to be hypertensive in life and their blood pressures are running 90, that may not be an adequate blood pressure. If their blood pressures are, however, at 90, they're adequately perfusing their kidneys, then the lower the blood pressure is, the better that is for the heart in terms of the work required. So the lower the afterload and the more optimal the preload for the heart, that is the venous return, the better the heart's going to do in terms of giving a chance for it to recover. And as I say, keeping adequate oxygenation is critical as well. This is one that I put in, not expecting too many questions. Should we consider a multi-center study or information gathering to determine which hearts with low ejection fraction will improve and which with time and intervention? I think that if nothing else, my getting this talk together and started educating me that we don't have the data. I knew that we didn't have data about how to predict what hearts were going to recover and what would make them recover. But we don't have the data even before that to start knowing what questions to ask. We don't know, we don't have the database available yet, which I think we need to do. And I'm prepared to like we did with the cath information sheet, where we asked cardiologists to minimum things required for a heart cath. I'm prepared to draft a document with some help from coordinators or other physicians in the transplant community of what data we need about potential donor hearts and what happened to the patient. Because I think our chance of bringing back more hearts and having more donor heart recovery is going to be dependent upon more information about what happened to that heart and individual and what was done to them. So in other words, right now, T4 is used across the board almost for donor heart at time of before transplant. A lot of people are using dobutamine as a way of trying to assess whether a heart's going to recover by what I would say is whipping the heart, because it's an inotrope and a chronotrope. The other thing is for Takasabus, some people are using estrogen now in an attempt to try and improve myocardial function with estrogen given in high doses for a couple of days, 1 or 2 days. I don't know if any of these are going to work, but I think we need more cooperation in the community to gather data, at least get some preliminary trial going where we look at historical data. Don't change what you're doing. Won't make anybody be forced into a protocol, but accumulate data on what various centers are doing and see what works and what doesn't work. Everybody believes what they're doing is making a difference. Maybe there's somebody out there doing something that's making more of a difference. And I would encourage that type of approach at this point in time. And I'll leave up to more questions. Do you have any more questions, Laura?
Yeah, we do. So I'll just go ahead and read these. The first one is submitted by Daniel Stouter. He says, could you please touch on the challenges presented by echocardiograms with suboptimal image quality? How do you typically, I know, like, there's a little more. How do you typically address it? Do you utilize an injectable enhancement agent, i.e. lipid-coated echogenic microbubble-based products, or do you opt for a different modality entirely?
Well, I think if it's just a question of what ejection fraction is, if you have an adequate look at the valves, because obviously with the drugs out there, endocarditis is an issue, and you want to make sure you're not dealing with congenital aortic stenosis or some other unusual valvular abnormality. If you have adequate look at the valves on a transthoracic echo, and the only thing you're missing is wall motion, and you can't determine wall motion because it's such a poor quality study, then contrast studies, echo contrast is of significant value. And even with the valves not being perfect, if you have a 25-year-old, if you get one glimpse of a mitral valve and the tricuspid valve and the aortic valve, you're probably going to say it's probably okay. But I think that in that circumstance where there's really a poor enough quality echo, another modality, transesophageal echo, should give you high quality imaging of wall motion as well as valvular anatomy and looking for leaks or stenosis. So it is a judgment call, and we will recommend to you which we think should be done in the echo report or verbally, so you know what our thoughts are.
Okay. Our next question is from Alicia Jackson, and she asks us, how often or are OPOs using Definity for difficult studies? If so, is there available training for that? And are there benefits outside of a visualization difficult study?
Well, that's the same question, almost the same question, Laura, because that's the echo contrasting. That's fine. Definity is one of them. There's several others, Opticon, and there's several others out there. It depends on what the hospital that you're working in is using, because usually they have a contract with one company because of volume. And it certainly does help you in terms of defining wall motion. It also can help define wall thickness, because you see a negative image, and that's usually the septum and posterior wall if you can get an adequate view of it. So yeah, it doesn't help where you have a subcutaneous air. Nothing helps in that circumstance if it's a trauma patient or a long-term ventilator patient. Those patients, you need to be able to get sound waves to get to the heart and bounce back in a somewhat clean fashion. So contrast material does help, and sometimes it doesn't.
Okay, we have another question here. A lot of them, I think, are some of these similar. And as I always say, full disclosure, I'm not clinical. I'm just reading these. Were any interventions besides time utilized on the case study shown? Points on T4 inotropes.
Yeah, inotropes.
Patients, yeah, inotropes.
Yeah. And I think, and clearly, I don't know.
Yeah,
that's
our challenge, right? That's why you pick up the phone and call sometimes.
That is exactly why I get on the phone and talk to the coordinators as to what, the first question I ask is what happened to him, and when did it happen, and how long ago, and how long was the downtime? Because if you want an opinion about what was the cause of it, whether it was one of the drugs that we mentioned or something else, and I think that and how many days ago it occurred. If first echo was done 5 days after a cardiac arrest and the ventricle is terrible, it's probably not going to get better no matter what you do. If, however, it's 12 hours after a cardiac arrest because of a hanging or a drug overdose, and the downtime is unknown, it was 30 minutes, or somebody said it was an hour, it's worth, if you can, to try some of these modalities. And we don't have the adequate histories. And I was very disappointed in myself and not coming up with a way of doing this, but this is focused me in this whole area of getting more information, and CompuMed's going to try and push the window of getting more information from the centers if we can, so we have a database, but it'd be great if it could be shared between OPOs rather than, and how we do that, I'll leave that up to the higher powers.
Well, and sharing information on the front end, and then also on, was it transplanted, so that we can start to track that differently. So it's both sides.
That is exactly right. The bottom line is we don't know whether these were transplanted. I know one of them was. The first one I did was definitely transplanted because I was told that by the coordinator. But beyond that, I do not know whether those other ones were transplanted. I can assume, but what assume does, it makes a ASS of you and me. You just.
And I will jump in on that case you mentioned earlier that we read, and we actually talked, with the medical director at that OPO, and we actually love follow-up questions for anybody that's on this and doing a post QA, if you will. We have all of our other reading doctors read it. We'll have 4 to 5 of the cardiologists look at it, and we learned quite a bit from that. They, went back to the transplant hospital. So, we love to do QA after the fact if anybody wants to submit those to us. Sorry, I'm just throwing that out there. More work for everybody, but we love to do it.
Absolutely.
Yeah, we learn. So another question, and I think these have come up in other webinars we've done. There are many different opinions on which pressors should be weaned first if the donor is on multiple pressors. What are your thoughts?
Yes. It is a matter of style as much as anything else. The medications that increase O2 consumption of the heart, that is the ones that cause more tachycardia, are ones that I would prefer to get off first. The ones that ease the work on the heart are the ones I would get off last. That said, you have to maintain blood pressure, mean arterial blood pressure, and you have to maintain perfusion of the organs. So you do what you have to do. I mean, when I was practicing on live people in ICUs for years and years and years, the final arbiter in terms of keeping people alive so they could talk to their visit with family members before they died was a drip of epinephrine and calcium. And people are appalled by that combination because it's maximal oxygen consumption. But it allowed them to perfuse their head enough to be able to say goodbye to loved ones. And I found that was useful in that setting because this patient was going to die regardless of what we did. Yeah, keeping the dose of dobutamine down to non-tachycardic doses is better than having it at higher doses. Dopamine, the same thing. We try and avoid Levophed. But in certain circumstances, Levophed works well. You try and use milrinone if you can. It is complex and depends on the individual situation and has to be evaluated at the time. And you need a sophisticated intensivist to help you with that on a moment-to-moment basis.
Well, you actually just pretty much answered the next question, but I want to bring it up again. So Michael Williams asked, you mentioned dobutamine, T4, estrogen. Is there utility for milrinone? And now I know how to say it because you just said it. So maybe you can expand on that a little bit more.
Well, there is in certain circumstances, but again, we don't have typically in patients where we use drugs like milrinone, we have hemodynamic monitoring devices in there. They're alive patients, so you're trying to get compensated from decompensated situations. In the setting of the potentially recovered heart, or the transplanted heart, you don't have that. So you're working in the dark. So it's a lot harder to use those complex drugs that rely on knowing what the filling pressures are when you infuse them. So it becomes problematic. And I think that's one of the reasons they're not used that much, because it is a difficult problem to try and pick the right dose. It's not like a shopping cart and you just put in 2.5 mics per kilo per minute or whatever of drug you're using. You have to know what you're doing and how you're doing it.
Good.
And why you're doing it.
Right now, there are no more questions. So we purposely kept this presentation part of this at half an hour because we know, especially in the OPO and the transplant world, you guys are super busy. So we're trying to keep these a little bit more staccato than an hour long. If you have more questions, go ahead and contact us. There's a few contacts on this last slide. And I think at the end of this, you can let us know if you want to reach out. I peruse the names and I see a lot of names on this that are current customers. And so you know where to reach us. For others, the information's on here. We'd love to share more with you. This will be sent back out to everybody that registered for a rewatch of it. Feel free to share it with your colleagues. And actually, if you go to our website, you can see all our some of our prior presentations on there too. We had Dr. Simpson talking about pediatric cardiology and the donor management of that. We had Dr. Angel talking about pulmonology a couple times. Dr. Shiroff has done, he did one on heart cath, and in December, late December, early January, we're going to be doing some pathology, and then we'll have a whole calendar again for 2023. If you can believe that, it's already that time of the year. We really appreciate everybody being on the call and for your time. And again, just reach out to us and let us know how we can help you save more lives also. Thank you.